It's really great to be here. Thanks, John, for the kind introduction. I'd like to welcome everyone who's from out of town or out of state to California and San Francisco. It's a really wonderful place to spend the weekend. And I also want to congratulate SOAP for putting on such a spectacular program, and it's a real privilege to be part of the program. I think there's a lot of exciting things to discuss over the weekend. I'm going to spend the first 30 minutes talking about whether it's possible to predict how long a surgical case will last. How many of you struggle with this at your hospital? Most everybody? Okay. I think as I've looked at this issue over the years, I think the take-home message is it would be nice to predict how long a case lasts to the exact minute. It turns out it's very difficult to do that for a lot of different reasons, and we need to work with the hospital to make sure that the estimates are as close to accurate as possible. It's kind of like predicting how long a baseball game is going to go. You have some idea, but it's hard to know to the precise minute. But as physicians, we need to work with the information systems that are available to us to make the predictions as accurate as possible, even though we know it's tough to get it down to the minute. In terms of a disclosure, I do some consulting occasionally, and over the past year, these are the companies I've worked with. And I'll give you an example of the kind of problem that comes up. This is a hospital in another state. They recently converted their medical record and enterprise system from mostly a paper-based system to an electronic medical record. And one of the purported benefits of switching to an electronic system, not only in the hospital on the ward, but in the operating room, was to be able to track case times more accurately, and that was going to lead to some efficiencies and help reduce the cost of the implementation of the electronic medical record. And not unlike what we've seen at other hospitals, after adoption of this fancy, expensive computer system that was tracking case times and using the historical data to predict the duration of cases, the accuracy of the OR schedule really didn't improve. And this was frustrating to the leadership of the hospital, but really not surprising to people that have gone through the exercise. And so let me just give you some of the main take-home learning objectives. The first one is that averaging historical data for case duration predictions often does not increase the prediction accuracy, and this is for a variety of reasons. And it starts at the time the surgeon decides to have surgery. You'd be surprised at how often when the surgeon tells the office assistant, we're going to do a cholecystectomy on this patient, that information is entered into the system incorrectly. And part of it is because we don't spend as much time as we should training the personnel that are booking the cases. So the surgeon might say, I want to do a cholecystectomy, and the assistant might type in lap chole, open chole, chole with API, and if you don't get that upstream initial coding, scheduling of the proper procedure done correctly, and this happens at every hospital that we've looked at, downstream things like trying to figure out how long cases are going to last are going to be impossible because you haven't actually booked the correct case. This is another problem that you'd be surprised at how often it happens. It turns out that many of the commercially available electronic systems, when you ask them for case times, if you look at the software and the algorithms that are being used, and you have to have people that are computer scientists to look into this, they're computing the time from incision to close as the case duration, instead of time when the patient went in the room to when the patient left the room. So if you're using incision close to predict future case durations, obviously you're going to underestimate the true duration of the cases 100% of the time. And if you can't figure this out, then all other attempts to improve accuracy are going to be challenging. I think the other reality about all of us that spend time in the operating room is that for a lot of surgeries, it's very difficult to do a standardized surgery with an exact sequence of steps. If case durations for a surgeon performing a particular procedure vary a lot, then it's intrinsically difficult to make good predictions, no matter how many cases are in the system. So for those of you that take care of patients that are having cesareans for Percreta, Some of those cases seem to go pretty well and they're over within not a long period of time. Other cases just take longer and they're more complicated. There's more bleeding. It's hard to predict how long that case is going to last. And there's variability in how long that case is going to last. So when we schedule an expert CRETA in the main operating room and we ask the system, well, it says a number, but there's a big standard deviation. And nothing we do as physicians will reduce that variation because the nature of the surgery is challenging. And for those of you that work at big academic centers, there's lots of surgeries that are quite complicated and can vary in duration. So we have to accept that uncertainty for those complicated surgeries. Another barrier to truth in scheduling is that the statistical distributions of case times they're not bell or normal shaped distributions. It turns out that most case distribution are what we call right skewed, which is that you've got some cases that last a lot longer than the average. And this right skewedness complicates using the average of historical case durations because unusually long cases, outliers, have a disproportionately large effect on the estimate of the next case. Another challenge for hospitals is that many hospitals use the surgeon estimate to enter into the computer to predict how long the OR is going to run that day. And the surgeon estimates of case duration may be consistently low if at that hospital there's concern of not being able to get all the cases booked within their allocated OR time. So if you want to get 5 cases in between 7 and 5, the surgeon is probably going to underestimate how long each case is going to last because the incentive culture system at that hospital says if you are going to start an elective case after 5, we're not going to do it. So the surgeons have a bias to underestimate how long their cases are going to last. So I'm going to blame the hospital and the system and the culture of the place because they're presenting the surgeon with a difficult problem is they want to get all the cases done, but they know they won't be able to start after 5. So unless you accept that and decide what you want to do about this problem, it's going to be hard to become more accurate in your scheduling. So let's talk about some of these in some more detail. The first one is faulty input data. I talked about the laparoscopic cholecystectomy, but this could apply to almost every surgery. You need to have proper coding dictionary so that different surgeons doing the same procedure, they're all booked in the same way. So it could be listed in the computer system as laparoscopic chole or lap cholecystectomy or lap chole. And so it could be that in the system, unless you dig and you probe and you ask, how are we doing this exactly, lists the same type of case in 3 or 4 different ways. So you need to standardize it so that every time a surgeon books the same case, it goes into the system with the same wording or number or terminology. And then the other challenge that you get into is that oftentimes a surgeon will do more than one procedure. So they might do the lap chole and sometimes there'll be an incidental API to do. They might have to do a liver biopsy. They might have to do just a lap chole. So it's common to see cases booked where there's more than one main procedure being done, but the amount of time that's being dedicated to that case is the same even if they're doing other minor procedures during the case. So you get this tension when you try to use historical case durations, which is you want to lump similar cases together. That way when you ask the system how long did these cases last, you've got lots of cases to choose from. On the other hand, the problem is if you lump these 3 types of cases together, each of them is really different and is going to require different times. So you have to engage with the computer system and the information technology people and work on each of these problems so that at the end you'll have some improvement in your case accuracy. The procedures that surgeons sometimes think they are booking versus what is actually being booked by the office may not be the same. And so what we've noticed at many hospitals is that there's enormous turnover in the personnel in the clinics. And so if a person leaves every year or two, that means that every year or two you need to train the people working in the clinics to make sure that they're scheduling the cases correctly. And that requires a dedicated effort. We talked about systems that may be using incision to close as the case duration instead of patient room in the patient out of the room. Please investigate if this is what's happening with your system. Another challenge that you face when you try to improve case scheduling accuracy is that what if the booked procedure ends up not being done? Then the time duration, what are you going to do with that? So if the booked procedure was a colectomy and they end up doing a different procedure, how should that duration be inputted into the system? Is it the procedure that was booked or the procedure that was actually done? And if you end up changing it to the procedure that was actually done, who's doing that? Is it being done all of the time? Now, this is an example of surgery outside of the labor and delivery suite, which is a Whipple procedures for pancreatic cancer. And for those of you that take care of these patients, you know that some of the cases, the surgeon opens the abdomen, that there's metastatic cancer all over the abdomen, and there's not much surgery that can go on. And that procedure takes a couple hours between the time the patient comes in the room and you put your lines in and you do the anesthesia and they open. Some of the other times, however, they open the abdomen and there is no metastatic disease that's visible, so they actually end up doing the entire surgery. Now that case ends up being about 5 or 6 hours. So at some hospitals, about a fourth to a third of the time on these cases, they close within a couple hours. The other 2/3 of the time, they do the whole procedure. So if you ask the system for the average time for tomorrow's Whipple that you've been assigned to, it's going to say about 4 hours. Well, that's going to be wrong 100% of the time, because it's either going to take 2 hours or 6 hours. It's not going to take 4 hours. So unless you understand the distribution of case times for the cases that you're doing in labor and delivery or even outside in the regular hospital operating room, it's going to be hard to be very accurate with the case duration prediction. Now, for sure, some cases are easier to predict. If you work with an obstetrician and you have a reasonably healthy patient and there's a cesarean scheduled, that should take a reasonable amount of time because the procedure and its steps are relatively well understood. Other examples of cases that are reasonably easier to predict are hysterectomy or hernia repair or cystoscopy, as long as that's the only surgery that's being done. In contrast, other cases are enormously, I would say almost impossible to predict. And these would be complex, unstandardized surgery. So for us, that might mean cancer surgery, either in the ENT room or in the general surgery room, or sometimes neurosurgical cases are completely unstandardized because each tumor is different. So it's much more difficult to predict how long those cases will last. And for sure, the longer any case lasts, the more difficult it is to predict how long it will take. And one of the things I've noticed at our hospital is that more and more we're doing big cases that last more than half the day. And as you increase the average duration of your cases, the accuracy is going to go down because by definition, the longer they take, it's more difficult to get it exactly right. Now, there are different ways to predict how long a case will last. Many of you work at a facility where the surgeon estimates how long they think their cases are going to last. Anybody using that system? Okay, a few. Other hospitals use the mean of the historical case duration as produced by the computer system. How many people do that? Okay. And then sometimes one of the things we've tried doing is to provide the historical case duration to the surgeon that's booking the procedure at the time of the booking and saying, okay, this case that you've booked has taken you 3.5 hours. Is that a reasonable estimate? Is anyone doing that sort of decision support with the scheduling proceduralist? I think that's helpful because sometimes the surgeon can provide input about the complexity of the case that may be otherwise difficult to discern by just looking at the booking record. And then another thing you can do is adjust for case complexity. You take the mean and then you adjust it for how simple or complex the surgery is. Now, mathematically, the way you assess the accuracy of the case scheduling system is you compute the prediction error. The prediction error is the estimated duration of the new case minus the actual duration of the new case. So if your cesarean is booked to take 90 minutes and it takes 100 minutes, that means that there was a 10-minute prediction error. And you take the magnitudes of the errors of the estimates. It could be 10 minutes too long or 10 minutes too short. And if you compute that for all your cases, you get your prediction error. Now, another aspect of accuracy is the bias of the estimate. Imagine if you worked at a hospital where every estimate was too low because of whatever reason. Maybe the surgeons are booking the cases and they are giving you low times because they want to fit all their cases within their block, or maybe the computer system is using historical data that's based on incision to close, not patient in to patient out. And so there are ways to assess the bias of the estimate. Is it consistently too high or consistently too low? And this can be just as important to discern when you're doing your analysis of why case scheduling is such a challenge. Sometimes we see in some hospitals that surgeons purposely overestimate case durations because they want to keep control or access to their OR time. They book one case, they say it's going to take 6 hours. We know it's only going to take 4 hours, but they want to keep the afternoon part of their block in case some new case comes in between now and Monday. And does anybody work at a place like that? Okay. So it's not always that surgeons will underestimate cases. Sometimes they will purposely overestimate. And what we've seen is that that depends on the service and the surgeon and what their practice type is. So again, if you want to increase the accuracy of the case scheduling, you have to get into this nitty-gritty details. Certainly, who the surgeon is or who the obstetrician is if you're doing a cesarean and what the surgical procedure are the two most important determinants of surgical time. So certainly when you get a new case, you want to figure out what the case is and who the surgeon is and see what those cases have been in the past. The skewness of statistical distributions of case times complicates just using the mean of historical case durations. So one of the questions that you're going to have to answer is, do we want to use the mean or the median, which is another way to represent the middle of a group of cases, because unusually long cases have a disproportionately large effect on that middle value. So this is data for our hip replacement surgery, and most of the hips are taking an hour or two. Sometimes in this hospital they were including revisions, and sometimes the revisions just took longer. They're complicated patients. They were taking 4 or 5 or 6 hours. So if you have this data and you have a hip that's scheduled tomorrow and the system doesn't differentiate between a revision and a primary, what time would you think we should schedule this case at? It's not a straightforward answer. So when you analyze historical case duration, you could use the median. It decreases the impact of unusually long cases. You could use a trim mean. Many of the computer systems are actually doing this, and you may not even know that, is they automatically delete the 10% lowest values and the 10% highest values and then take a mean. And other systems use a geometric mean, which is just another fancy mathematical way to figure out what a middle value is. In general, our recommendation has been pick a number so that cases finish before 5 o'clock, if that's how long your block duration. Because the overtime cost, not only in terms of financial overtime cost of everybody in the operating room, and the morale cost of consistently having rooms that run late, is much greater than the cost of finishing early. So generally, the approach to OR management is figure out a way to get all of your elective cases done during regularly scheduled block hours so you don't have to pay or have unexpected overtime. And so that seems to work for most facilities. It turns out that if you want to estimate a new case's duration, the trim mean provides values similar to the sample mean. And that's because a majority of cases have fewer than 10 similar occurrences of the same procedure by the same surgeon in the recent past. And this was another great surprise to us when we started looking at this problem, is that how few cases of the same surgeon doing the same procedure there often are in hospitals. And another problem that we haven't talked about yet is, what about cases where there is no prior data by that surgeon doing that procedure? So if you hire a new obstetrician and they're scheduled to do their first cesarean tomorrow, how much time should the system give the new obstetrician to do that cesarean? Well, you could take the average of what everybody else is doing, which seems to work pretty well. But I think we have to understand this basic problem of how few cases that are of the same surgeon and the same procedure. So this is another hospital in another state. They have the main hospital. They do 11,000 cases. They have an ambulatory surgery center. They do about 5,000 cases. If you look at the number of CPT codes that are performed at the hospital, there's about 5,000 different CPT codes, which seems like a lot, but if you look at each CPT, there's lots of different procedures that are being done. It's a lot less at the outpatient surgery center. There are about 200 surgeons at the main hospital and 160 at the ambulatory surgery center. The median case duration is 2.5 hours in the main hospital and a little bit over an hour in the outpatient surgery. Well, if you go into the computer system and you track the combinations that are unique of procedure and surgeon, there are about 7,000 unique combinations of procedures and surgeons. And that might be a little surprising at first until you realize that if you go into the hospital and you ask them how many preference cards, they'll say we have 5,000 or 6,000 preference cards. Well, every preference card defines a surgeon of a specific name doing a specific surgery. So if there are 5,000 preference cards at your hospital, that means that the hospital believes there are 5,000 different cases. Now, if the hospital is only doing 10 or 12,000 cases total, there are going to be lots of cases where you have lots of historical data to go on, but there are going to be lots of cases where you don't. And I think we have to appreciate that. So, for instance, if there are 7,000 combinations of surgeons and procedures, one approach could be you could lump together similar CPT codes. But this turns out to be impractical because procedures that differ only in the 5th digit have very different case times. So, for instance, for the people that work in ophthalmology surgery, a vitrectomy takes longer than a sclerobuckle, and the CPT codes are quite similar. So it would be tempting to group those together to get more cases for which to base tomorrow's ophthalmology schedule. But if you do that, you're going to mix two very different types of cases. In other words, limiting consideration to the primary CPT code that's booked is impractical because cases with the same primary code but different secondary codes have very different surgical complexity and case time. So going back to the lap chole, if we just book the lap chole and not book the incidental API or the liver biopsy that need to be done, and if we don't include those, we're going to have even less cases on which to base the prediction for tomorrow's case that's being scheduled now. And so in general, what we found is that about a quarter of cases that are booked in an outpatient surgery center by a particular surgeon don't have any cases in the prior 12 months for which the computer can take an estimate for what the next case. About a quarter of the cases have lots of cases, and then a lot of surgeries have 5 to 15 cases, which is a reasonable number. So when no historical time data are available for a new case, use the surgeon's prediction. So if you have a new obstetrician and they're going to do their first cesarean, just ask them. Or you can take the mean of the durations of other cesareans performed by other surgeons, and this is as accurate a predictor as other more sophisticated methods. Now, the reason this lack of historical data with similar surgeons doing the same procedure is important is because if there are 4 or 5 cases in your room and 1 or 2 of those don't have any historical data, that's going to mess up the schedule for the entire day. So all you need is one case in your list to complicate the accuracy of the day schedule. Now, a lot of hospitals, in order to have the correct surgical equipment and supplies available for a case, use procedure mnemonics, where they kind of group things together. So, for instance, at our hospital, we have this thing called ABGN 8105, which is a particular group or type of cases that require the same kind of surgical instruments. Now, the problem is it might make sense to use this coding to figure out what surgical tray and instruments to make available to the surgical team, but it's not very useful if that's how the next case is being booked, which is what happens at a lot of hospitals. They're using the procedure mnemonic, which dictates what supplies should be made available, as the way they're predicting the case duration. So this is ABGN 8105 at a hospital in Northern California, and they list the mnemonic and then the procedure that was actually performed and then the pre-op diagnosis. So you'll notice there's lots of different types of surgeries. To us as anesthesiologists, maybe it doesn't matter because we do the anesthetic and we wake the patient up for the surgery. But in terms of figuring out how long it's going to last, it makes a big difference whether you're doing all of these things and in what kind of patient. And so the challenge for people that study this is to lump or not to lump. Do you want to put cases that are similar together to have enough cases to really make a mathematical prediction, or do you not want to lump cases because every case really is unique? Let me reemphasize that estimating the case duration is only helpful if the surgeon correctly schedules the operation they do. This is an example from a couple weeks ago that we had to discuss at our scheduling meeting. The surgeon had scheduled, the urologist, a cystoscopy with bladder biopsy plus uteroscopy cystoscopy with retrograde pyelogram. So this is what was booked. Only the cystoscopy was done, and then the case was over. And so when we educate the computer about what time should be allocated to the surgery, the question is, how should that be done? And it's labor intensive to discuss every case where the booked case isn't what actually got done. And so unless the system takes that challenge head on and has a system to close the loop, then the data in the system are going to be faulty. And you may decide it's not worth it, and that may be part of the reason the accuracy is still a challenge. I think that best practice now, because the OR is such an expensive place to be for hospitals, is for there to be some kind of process feedback closing loop where you adjust the recorded descriptor for the surgery that was actually completed, not what was originally scheduled. Just to finish up in the last couple of minutes, please appreciate that even when many previous cases are available for estimating, cases will still end late or early because of variability in surgical times. And for example, if the true median and standard deviation for a breast augmentation is a couple hours, then increasing the number of previous cases used to estimate the time of the next time a breast augmentation is scheduled may improve the accuracy of the estimate from 1.8 to 1.9 hours if the truth is that the mean is 2 hours, but the standard deviation is still 0.7. There's variability in how long it takes to do surgery. It's impossible for us to reduce some of that variability in how long it takes to do surgery and anesthesia for that matter. So we have to learn to live with some uncertainty in how long cases last. So what do we do about that? Well, I think we have to remind ourselves that it would be nice to have no uncertainty. It is present. The problem is that a lot of times we're looking for a single number. The data will be really helpful in getting an assessment of the uncertainty about how long a particular case will last. So if you want to take that, best practice is to accept this uncertainty and manage it somehow. So we know it's difficult to predict what time the patient who's having 3 o'clock surgery should come in, because we don't really know when the case before then is going to finish because we don't really know when the 2 or 3 other cases before then are going to finish. So there's this complicated practical problem, which is when should we have patients that are scheduled to come in at 3 come in? Well, if it was completely accurate and we knew the case was going to start at 3, we could have them come in an hour beforehand and it'd be fine. The problem is that if they come in an hour beforehand, a lot of times, some of the times, enough of the times, we'll be ready at 2 o'clock and the patient won't be there. And all of you that work in an operating room know how frustrating that is because we work hard to run a quick operating room and then the patient's not ready and it sort of grinds the operating room to a halt. So the alternative is, all right, let's get the patients in 3 hours earlier. And that's okay as long as you've enhanced the waiting experience. So I think patients don't really want to wait 3 hours before their elective surgery, come in at noon for a 3 o'clock case. But if the hospital takes some initiative and improves the waiting area, provides, I guess, coffee for the family, not the patient, provides Wi-Fi, if there's an elective cesarean scheduled at 4 o'clock, I mean, what can the hospital do to make that entry into the operating room more agreeable? Some hospitals have airport-type monitors where you can actually see where you are in the queue. You might be delayed, but at least you know you're delayed. You have more information. Some facilities give the patients pagers and say, go get some shopping done, and we'll call you when there's 30 minutes. Anybody doing that? Not too many. You can take it as an opportunity to do some patient education. So we know it's tough to predict exactly what time that case is going to last, but we can do something to improve the patient wait experience. To finish up, please don't underestimate the problem of faulty scheduling input data. It's so easy just to go toward more easy to think about concepts, but if you don't fix the scheduling right from the outset, it's going to be a real challenge. Obviously, you have to identify who the surgeon is and what the procedure is because of the 2 most important determinants of case duration. The statistical distributions of case times is not bell-shaped, and so the mathematics of figuring out what number to use are complicated. Accept the uncertainty of case duration directions and figure out a way to try to manage some of that uncertainty. Thank you.